So I think I really tried hard to talk about advances in radiation oncology without any technical advances, and I found I could not do it. So I do need to talk about some technical advances first. So I think that in the last 15 years, there have been significant improvement in the delivery of radiation therapy. So we talked about acronyms before. Radiation therapists love acronyms too, and as you can see, they're all four-letter acronyms, IMRT, especially now with a next generation IMRT called VMAT that allows us to give the radiation dose more quickly with the patient on the table. Usually with a full bladder, that's actually a big bonus because I think that before patients had a hard time sort of lying on the table of the radiation treatment room with a full bladder to keep still because that's what we try to do. We also actually have proton beam radiation therapy. I'm not going to talk about that. That'll be sort of, I think, covered later in the day. But we do have a newer technology called scanning beam or pencil beam, which allows us to give a better distribution of dose with proton beam. We also have image-guided radiotherapy or IGRT, which allows us to take images every day to make sure that the radiation is being given to the prostate every day and that the rectum and the bladder are being missed with the radiation treatment, which allows us to give a higher dose of radiation safely so that it's more effective as well as the risk of side effects is reduced. I think we're also sort of focusing on increased imaging with radiation therapy. So I think we're trying to incorporate MRI scan into the actual planning, which is a simulation, as well as the actual treatment delivery on the machine. So we're actually looking at getting an MRI linear accelerator, which will actually have an MRI scanner actually on the machine that gives radiation treatment. I have actually visited some facilities also have an MRI simulator, which actually uses the MRI scan for the actual planning process, which makes it a lot easier for us to identify where the prostate is and where the cancer is on that prostate. Now, however, the radiation therapy is a local modality of treatment. So the actual graphs that you see is the results from MD Anderson of patients getting treated with high-risk prostate cancer. On the left, you actually have different curves looking at local failure. If you look at the top curve, let me see if I can, oops. Let me see if I can get this in. So the actual top curve is what you want to see is that's actually given with high dose of radiation therapy defined as 75.6 gray of radiation or higher with 2 years of hormone therapy. As you can see, local failure is 0%. So that means that we actually get 100% local control with the radiation treatment. However, when you look at the right, that's actually the PSA control. As you can see, the cure rate for that is about 75%. So there's about a 25% chance that the cancer will recur even when we have full control of the cancer in the prostate. So this tells us that, especially with high-risk cancer, it's more of a systemic problem, and we're able to only control a certain percentage of those patients with radiation treatment, which means that we need to do better in terms of taking better advantage of both radiation and cancer biology. And I think that's where the next advance of radiation therapy will come, because I think that in terms of radiation therapy delivery, I think we sort of have almost maxed out on what we can do. And so I think what I think is that we can actually take advantage of hypofractionation or really use stereotactic radiotherapy. And that could be done for both definitive and for oligometastatic disease. I think we need to do better integration with systemic agents. I think we sort of finally have gotten to the point where we feel comfortable with combining Lupron with radiation therapy. But there's so many new agents that we haven't really had a good way of integrating, such as abiraterone and enzalutamide. And I think we sort of also recently saw a trial called RTOG 0521, which suggested that docetaxel, in addition to the Lupron, to the radiation therapy, may improve outcome in terms of survival. I think definitely the neurobiologic agents and the immunotherapy, we really have no idea how to combine with radiation therapy as well. So I think that we actually do have a lot of work ahead of us in trying to incorporate these neurosystemic agents with radiation treatment. And I think I'm going to talk very briefly about genomic testing because I do see this quite often in my clinic where the patients come with the results of their tests, and I'm not sure exactly what to do with those. So in terms of hypofractionation or the reason for stereotactic radiotherapy or higher doses per day, it's really this sort of survival curve. So if you look at the curves, the one that's actually sort of more slope going downward is the late responding tissues, which you sort of consider prostate cancer to be. And what happens with those tissues is that as you increase the dose per day or dose per treatment, the response is greater. In fact, what happens with prostate cancer is that compared to normal tissues, the actual response is greater at higher doses. So that by giving higher doses, we're able to give a higher chance of killing the cancer while actually causing less damage to the normal tissue. So I think that has sort of taken quite a bit of, I think, advancement in the recent 2-3 years where a lot of patients are being treated with something called SBRT or stereotactic body radiation therapy. I think I said that we do love acronyms, so we also call it SRS or stereotactic radiosurgery. And my favorite, this is actually coined by our lung cancer colleagues called SABRE. So that's actually stereotactic ablative radiotherapy. I think that in terms of technical competence, it does require more work. And I think that's where I think the technical advances over the last 15 years has really helped, because now we're able to do both better planning and better targeting and better delivery of the radiation therapy to these patients, so that when you actually look at the outcomes, they actually look quite good in both terms of the cure rates as well as risk of side effects. There are multiple ways of giving these SBRT. We have a technology called CyberKnife. Gamma knife is actually more for the brain as well as the cervical spine. And then we actually do LINAC-based stereotactic radiotherapy at MD Anderson. So once again, I think that the whole theme of the stereotactic radiotherapy is the fact that there is some knife involved. So I threw in a picture of the lightsaber in there just to kind of, get the going. There is no scientific reason why the lightsaber is on that slide. But in terms of why SBRT, as I said before, it may be more effective than conventional fractionation. And not only do we use it for prostate cancer, but I think, we actually tend to use it for more classically radiation-resistant tumors, such as renal cell carcinoma. In fact, I think I've actually sold the SBRT onto my GU medical oncology colleagues, because every time they sort of see a bone met from an RCC, they tend to send it our way for SBRT. I think that in terms of the actual treatment, it's very similar between whether it's the prostate cancer treatment or the renal cell carcinoma treatment. And when you look at the actual effectiveness of the treatment, it's actually very similar, which sort of shows that with the SBRT dosing that we give, we're probably able to overcome the radio resistance of the cancer cell. It's definitely more convenient for the patient. So we used to treat patients. In fact, we still do treat patients to 8 to 8.5 weeks of daily treatment. With SBRT, for definitive treatment, that could be done within about a week to week and a half. So it's much more convenient. For oligometastatic disease, whether it's bone or soft tissue, that could be done within 1 to 3 days of radiation treatment. So I think that for the patient, it's much more convenient. And for my sort of genetic oncology colleagues, they really love that, because they actually can continue to give systemic therapy while the patients are getting the SBRT, because the fact it's such a short course of radiation treatment. And so it's treating a much smaller area of normal tissue. There's a lot less bone marrow suppression, and probably less effect on the sort of the critical organs as well. So I think that once again, using SBRT allows them to continue the systemic therapy while the radiation therapy is given. And I'll touch on this too, is that I think with the SBRT or any radiation therapy, there's a chance for abscopal effect for sort of potentiation of immunotherapy responses. So this is actually one of my patients getting treated with SBRT, or gone treated with SBRT. What we're able to do is we're once again able to treat a very small area on the prostate to minimize the risk of side effects to both the bladder and the rectum. This is kind of a busy slide, but it's really just a tabulation of the results of SBRT for definitive treatment over the last several years. This column is actually the biochemical relapse-free survival. As you can see, it usually ranges between 90 to 98% or 99%. So the actual cure rate is actually very high. There is a 74%, but that's actually in high-risk patients. So once again, revisiting the theme that for high-risk patients, there's about a 25% of patients who actually fail local therapy because of systemic disease. If you look at the actual toxicity, usually it's pretty low. It's comparable to actually longer-term conventional treatment. So once again, I think SBRT appears to be both effective and safe in terms of treating patients with localized disease. We're actually now looking at using SBRT for treating bone mets and actually soft tissue oligomets. This is actually one of our patients getting treated with SBRT to a bone met in the SI joint. The actual tumor is right here, sort of outlined in red, and it's getting 16 gray in one single fraction. So if you actually did the math or did the modeling, that'd be equal to about 60 gray at 2 gray per day. So it's a much higher dose. And I think that what we're trying to do is see if that actually does a better job of controlling the pain, as well as decreasing the actual need for additional treatment down the road. And actually, while doing the literature search for this talk, I came up with I came to actually this paper on PubMed, which is very provocative, where it sort of shows in a case study that using SBRT for oligomets may delay the development of castrate resistance. So once again, I think that there is a role for treating oligomets in these patients who are most likely going to live at least several years, if not longer. So I think that once again, we're being more aggressive about treating these patients with limited number of metastatic disease. And once again, when you look at the actual local control rate, and these patients get treated both bone and lymph node recurrences, the actual local control rate is actually very, very high. So once again, it shows that SBRT can lead to very high chance for cure or local control with low risk of having side effects. I'm going to shift gears and actually talk about how sort of radiation therapy may play a role in sort of combination with immunotherapy. So I think you've seen these kinds of slides in the past. This is the abscopal effect. So what radiation does is cause both increasing antigen presentation and cell kill, which then sort of potentiates the immune system. And the cytotoxic T cells that are sort of revved up then kill cancer cells at a different site that's not radiated. And so I actually look at the literature to see if there's any studies looking at this. There was this one phase 1, phase 2 study that was done by Dr. Slovin, I think Amora Sloan Kettering et al. At multiple centers. And I think what they did was they actually looked at castrate-resistant prostate cancer, which were metastatic. They gave, in a phase 1 fashion, 3 dose levels of IPI, 3 milligrams, 5 milligrams, or 10 milligrams per kilogram for the patient. And then once they sort of realized that there was no MTD reach, they were actually able to give 50 more patients with 10 milligrams per kilogram of IPI with radiation treatment. So in terms of the patients treated, there were 70 patients treated in the phase 1 aspect, and an additional 50 patients treated phase 2. A lot of the patients actually got radiation treatment with the IPI. Most of the patients got a single fraction of 8 gray, either to 1, 2, or 3 metastatic sites. This is the actual response of the patients. So on the patients who got the 10 milligrams per kilogram with the radiation therapy, as you can see, there was some complete responders as well as partial responders. Unfortunately, there was some price to pay in terms of toxicity. So this is a pretty busy slide, but it does show that there is some toxicity associated with the ipilimumab when given with the radiation treatment. There was a phase 3 study, this is by Dr. Kwon et al., looking at, once again, patients who have castrate-resistant metastatic prostate cancer, in this case, who actually progressed after docetaxel chemotherapy. Once again, there were about 800 patients randomized to this trial. Once again, the patient received 10 milligrams per kilogram of IPI, and then the radiation therapy was once again 8 gray times 1, either to 1 to or up to 5 sites of bone mets. And just like with the phase 1, phase 2 trial, the radiation was given about 24 to 48 hours before the actual IPI was given. And once again, when you look, this is actually the progression-free survival. And there is actually improvement with the addition of IPI compared to placebo with a p-value, as you can see up on the slide. When you look at the overall survival, there was a slight improvement with the IPI. The problem, I think, was that the p-value was 0.053, so just slightly above significance in terms of statistics. The patient or the study actually did look at sort of a subset analysis. So in the patients who were looked at having sort of what they call favorable features. So what they said was the ALK phos was less than 1.5 times of the upper limit normal. The hemoglobin was greater than 11, and there was no visceral metastasis. There was actually an improvement in overall survival with the addition of IPI. If the patient had one or more of those adverse risk factors, in terms, once again, the ALK phos being elevated, hemoglobin being low, or having a visceral metastasis, there was no improvement whatsoever with the addition of the IPI to the radiation treatment. So I think that if you look at, once again, the risk of side effects, there was some toxicity with both the immunotherapy and the radiation treatment. So if you look at sort of the cost of immunotherapy, radiation therapy, I think it does look very promising. But I think it does open up a lot more questions that needs to be answered. Because I think that in terms of the radiation therapy, which ones we target? Do we sort of target all the bone metastases, or do we sort of target the symptomatic ones or the largest ones? What's the optimal dose and fraction size of the radiation therapy? Because once again, these two studies did 8 gray times 1. There's some animal studies that suggest that maybe a fractionated course might be a better way to sort of increase the abscopal effect. So once again, I think that needs to be studied. In terms of the timing of the radiation therapy, once again, these studies looked at radiation therapy given 24 to 48 hours before the actual IPI administration. So the question is, would it be better to give the IPI first, then the radiation therapy afterwards? I don't think we know that answer at this point. And I guess finally, like, what agent or combination agents do we use? We sort of talked about IPI, but there's so many more agents that are possible now, as well as other agents you can combine with the immunotherapy agents. So I think that in the end, that's going to be a lot of questions that we need to answer if we need to sort of figure out what radiation therapy or how radiation therapy could fit into the metastatic castrate-resistant picture. I did want to talk about genomic testing very quickly. I think that, I see patients in clinic, and I get these questions all the time where they have a copy of their genetic testing. Usually, I think probably most commonly from Polaris or Prostavision. And I'm not exactly sure what to do with these patients, because in the end, there is some, I think, data regarding how these patients will do prognostically. But in the end, I think that it's very limited in terms of how that plays into the decision to give treatment. There is some data, I think, from Decipher about sort of metastatic disease after surgery. And so I think then the question is, do these patients, does that Decipher test sort of push you to recommend adjuvant radiation therapy more or less? And I think that, we don't know that answer either. So I think that these genomic testing, I think, are interesting, but I think right now I'm not exactly trying to incorporate that into clinical practice. But I think that hopefully we'll be able to do additional testing in the future to be able to better use this information that we get from the patients to sort of figure out what best treatment they need to get. The other thing I sort of wanted to sort of throw out there was that we definitely see patients who get radiation therapy. And I think in the end, all of our patients have treatments that meet certain criteria of radiation dose given to the tumor and radiation dose given to the normal tissues. But some patients have more side effects than others, which I think sort of tells me that in terms of the actual sort of the patient themselves, there is a risk factor for increased radiation side effect. I think that's probably we need to sort of tease out whether these patients have a sort of a actually genetic risk factor for radiation toxicity. And I think that if we're able to identify those kind of markers, that may help sort of better guide whether or not the patients should get radiation therapy or surgery or systemic therapy. So I think that once again, that should help us do personalized medicine, which I think is sort of the buzzword now. So in conclusion, I think there have been significant advances in the delivery of radiation therapy in the treatment of prostate cancer. I think SBRT offers a very attractive, short, effective way of doing radiation therapy for both definitive treatment as for oligometastatic disease. I think additional testing is needed to figure out what is the optimal sort of integration of systemic therapy with radiation therapy, especially with the newer agents. And I think that the use of genomic testing should be validated, but in the future, hopefully will help us guide which treatments to use, as well as I think, in terms of predict toxicity after treatment. Thank you very much.
Thank you very much. Quick question. ASTRO just happened. How many fractions do you think will become the new standard for treating prostate cancer? I'm seeing you looking for a very hypofractionated approach. But what do you think the standard is based on the new ASTRO data?
Well, the problem is that I think we have now at least 4 randomized studies I know of that show hyperfractionation shows the same outcome as sort of conventional fractionation.
I thought there's a little bit more late GU toxicity, at least that's
potentially, but I think that in the end, in terms of the actual p-value, they're not statistically significant. So in fact, we have one at our institution looking at 2.4 gray times 30 or 6 weeks of radiation, which looks very similar to the 42 that we did at the time. I think that for some reason, we, as a sort of field, have been very slow in adopting that hypofractionated treatment. I think the actual protocol or study that was published this time or presented at ASTRO, that same fractionation was used by the Cleveland Clinic, and that's been like done for now more than 10 years. We actually have long-term data on that. So I think in the end, I think my feeling is that we haven't really moved as a field to the hypofractionation scheme. That being said, I think some of these more extreme, I think, is getting more popular. So I think that with CyberKnife, I think with Linac-based SBRT, and I think there's more and more data that support that even with high-risk cancer, at least in some high-risk patients, the SBRT can be used. I think that may sort of be more popular than sort of the moderate hypofractionation that we sort of talked about.
Cool. All right. Yeah, Deb.
Being one of the other, I think, fairly few radiation oncologists in the room, I'm going to comment because as Seungtaek said that we did do that trial that's moderate hypofractionation. So 2.4 gray a day, 2.5 gray a day to equivalents of 70 gray or so. Is quite safe. I think that's what was said at ASTRO. But the dose equivalent of that is 80 gray at 2 gray a day, or 85 to 86 gray at 1.8. So what you have to remember is these are not made, typically these trials have not been made to be dose equivalent, but they are dose escalated. And anytime you get up above that mid 70 gray level, you have got to be careful with it. It's not for everybody. You have to be extremely respectful of the normal tissue. So you can prevent a lot of complications if you're just a little bit selective, but I think we're going to see more and more hypofractionation. The treatment courses are all going to get shorter, but the extremely hypofractionated, like the 10 fractions, the 5 fractions, they are not ready for prime time. This is not standard care. They need to be done on studies.
Okay, so 5 to 10 is not standard care for sure.
Yeah, usually it's 5 because to get the billing for SBRT, it's got to be 5 or less. So it's usually 5 treatments. With I think the hypofractionation, I think that it depends a little bit on which sort of study you follow, but the most commonly has been around 25 or 28 to 30 treatments.
Okay,
Still takes 6 weeks.
got it, got it. Terrific. Thank you very much.